Hyderabad, followed by roles as a tutor at BCM School of Nursing and an assistant professor at Sahara College of Nursing. Accompanied her is our esteemed speaker, Dr. Monica Hendricks, ma'am, who will be shedding light on the topic Policy Making in Midwifery, Improving Maternal and Neonatal Health through Evidence-Based Regulations. Before we begin, I would like ma'am to kindly come upon the stage. Now I invite Mrs. Anamika Chaurasia ma'am to extend a warm welcome by presenting a live plan to both of our chairperson and speaker. Thank you so much, dear ma'am. Now I request Sister Maggie Jose ma'am to kindly formally introduce our speaker. Over to you, sister.
Good morning to all. Welcome back after a high tea. Esteemed gathering, distinguished guests, and all the panelists, vibrant and dynamic students, the audience. I'm glad to introduce about her leader, Miss Monica Rita Hendrick, a vibrant leader, a dynamic leader. A good leader possesses several key qualities which inspire and guide others towards a common goal. A leader has a clear vision of the future and inspires others to work towards that common goal. A leader who knows the way, who shows the way, and who goes the way. So let us invite Ms. Monica Rita Hendrick, the panelist of this, the speaker of this particular session, on the particular topic on policy making in midwifery, improving maternal and neonatal health. Over to you, ma'am, and all the best.
Thank you, Sister Maggie, for that introduction. Honorable Chairperson, all the guests of honor who are occupying the first seats, and all the students who are part of this workshop. So a warm good afternoon to all of you. So today I would be enlightening you on what is midwifery, how is it different from obstetrics, yeah, and enumerate the roles of midwives in improving health outcomes, examples of evidence-based policies in midwifery, especially in the state of Uttar Pradesh, the key components of policy making in midwifery, the challenges affecting the success of midwifery in India, and the strategies to overcome these challenges. So this is, okay. So this is the statistics. This is a very rough statistics for you to get an understanding. So our population is 1.46 billion approximately, out of which 22.2% of the women are in the reproductive age, and the requirement of an OBGY is 1:1,000. And we have an approximate of 70,000 OBGYs. That is about 40% less from the needed amount of, or the needed number of midwives or obstetricians that we need. So, can I ask the students a question? What is the difference between an obstetrician and a midwife? Can I have a volunteer? Or should I pick you up from the group? What is the difference? What is the difference between an obstetrician and a midwife? There is no right or wrong answer. I understand that the concept of midwifery is pretty new. We may be confused. It is okay to, give me a wrong answer, but I need the confidence in you to get up and give me an answer. What is the difference between a person who finishes MSc OBG? What is the difference between a midwife? Are they the same? Okay, are they the same? MSc OBG and midwifery, are they the same? Yes? No? How many of you say yes? Raise your hands. They are the same? They are different. How different are they? Yes? Okay, I'm very glad she got up and she at least answered. Please give her a round of applause. But the difference wasn't all that clear, but I love the attempt. So the key differences are the training and qualifications. In BSc nursing, we learn obstetrics, we learn gynecology. Yeah? But to become a midwife, you have to learn a course called as Nurse Practitioner Midwife. So that course is about 18 months long. You can finish your GNM, BSc, and after which you should have 2 years of experience in a hospital which has obstetrics and gynecology, and you've been serving in that particular OBG ward or the labor room. Okay? So there is that particular difference. The scope of practice. The scope of practice, as you all know, those who finished MSc obstetrics, those who finished even BSc, work in the ward as a staff nurse. Whereas the nurse practitioner midwife, her role is a little different. She gives care for a mother during the antenatal period, the intranatal period, and postnatal period, but it is a very woman-centered care. It is not fragmented care, it is very woman-centered care. And the approach is again very woman-centered and holistic, whereas a midwife, an obstetrician is taking care of an obstetrician, be it a doctor or be it a nurse who has finished MSc OBG, the care that they provide is very different. It is very medical. It deals with complications. It deals with gynecological issues. Whereas midwifery normally deals with the normal process of motherhood, labor, and the postpartum period. Okay? So all of you got the difference between obstetrics and midwifery? So midwifery is again the care provided to a mother during the antenatal period, the intranatal period, and the postnatal period. And the key characteristics are optimizing the normal biological, psychological, social, and cultural processes of reproduction and early life. A normal obstetrician, an MSc OBG nurse, is not going to look at the psychological, social, and cultural processes, whereas a midwife takes care of the woman, keeping in mind she comes from a particular culture. She needs culture-specific care. Her needs, respectful maternal care, concern for the mother, allowing a partner to be with the mother, educating the partner during the antenatal period to help the pregnancy move forward. Timely prevention and management of complications. Midwifery concentrates on prevention and management of complications. It actually concentrates on timely prevention of complications. And once they identify a mother has some complications, they immediately shift the mother to a more specialized, higher level of care. Obstetricians deal with complications and more difficult labor and difficult pregnancies. And consultation and with and referral to other services is another role and responsibility of being a midwife. And working in partnership with women to strengthen women's own capabilities to care for themselves and their families is the key concept of midwifery. So, in one word, if you look at midwifery, it is woman-centered care. We are not looking, in normal care, what happens? The doctor is the main person. Doctor tells, you know, your labor pain has not started, let me induce you. It is the doctor's decision. Of course, they get consent from the particular patient, but doctor is the central person, or the nurse there is the central person where we're just providing information. But in midwifery, the mother becomes the key person. They discuss with each other, they speak about alternatives, and the mother and the family gets to choose how she wants to be taken care of during the antenatal period, intranatal period, who she wants to have by her side, how she wants to be taken care of, and we try and make the entire process as normal as possible. I would like to quote an example to you. In those days, did we have obstetricians? Did we have doctors with complicated degrees, nurses with doctorate, double doctorate? Didn't women deliver normally those days? They used to go to the field, they used to go to collect firewood, and she used to deliver the baby and come back. So delivery and the entire process of pregnancy, humans being mammals, can happen in a very normal way. We need not give fundal pressure, we need not give medications, we need not go against nature. I'm not denying the entire process of, instrumental delivery or extended support for delivery. Of course, there will be complications, and that time we need higher levels of care. But sometimes what is happening right now is that too much of emphasis is given to medical care, medical support, which is not required for a normal case. Even if you look at a woman in labor, if you have conducted delivery, you wait patiently, you will see all the steps in the mechanism of labor happen. Internal rotation, restitution, the baby will come out normally. That's nature, that's God's way of getting a baby out. We need to intervene only when there are complications, and I feel a nurse, a midwife can do an excellent job at it, and unless and until a complication arises, that is when you need to refer the patient to a higher level. So that's about midwifery. And who is a midwife? So a midwife is not a person who has completed OBG as part of her requirements in her undergraduation, or OBG as a part of her requirements in post-graduation. She has to finish the nurse practitioner midwife course, which is actually very much in line with the International Confederation of Midwives guidelines. The syllabus is framed in discussion with looking at these guidelines, and it should be duly recognized in a country. So some years ago, we did not have the concept of midwives in India. It is a recently evolving concept. People have started thinking that, midwifery is better, having midwives is better, and I will explain to you why is midwifery better than an obstetrician. So why midwifery? Anyone, can you tell me why do you need midwifery? Why? I think now you got an idea. You know what is the difference between an obstetrician, an obstetric nurse, and a midwife. Why do we need midwives? One of the reasons already is depicted in the statistics. We do not have enough manpower. Our population is 1.46 billion. 80% are in the rural areas. People who finish high level of education do not want to go to rural areas. We want to be in the most super specialized hospital ever. So who is going to take care of 80% of the population who are actually at the rural level? So one of the reasons why we need midwives is to cater to the needs of the population. And that too in India, we all know that we are quite a populous country. So we need support. So that is one reason. Any other reason as to why do you think midwifery is essential in India? Please give it a shot, students. Why? Think, why? Why do you think midwifery is needed in India? Yes. Can you get up and, speak at your loudest possible voice? To reduce the complications. Okay. To reduce mortality, morbidity, both maternal and neonatal. Okay. Okay, good. So sometimes too much of interference, too much of medical interference causes a lot of complications. So letting the mother progress naturally will actually give us a breather and help in reducing a lot of our morbidity, maternal and neonatal morbidity and mortality. So the first thing is, the reason why we need midwifery is quality health services. In midwifery, what happens is that one midwife takes care of the mother all through her pregnancy. So a woman who visits the OPD meets the midwife and she keeps following up with her, and if everything is fine, she is the person who is with the patient till she delivers, till she reaches her postpartum period. So what happens, you become very confident, and a midwife has a lot of time. A doctor comes to the ward, sees the patient, prescribes medications and moves away. I'm not blaming a doctor. The scope of work of a doctor is like that. Whereas a midwife is a nurse primarily, and she gets to spend a lot of time with the patient. And if you noticed, if you have worked in the ward, patients are more comfortable talking to you, telling you their issues. So in that case, quality of services is better because the nurse or the midwife is there with the patient, giving all her time, all her attention. As my friend over there had said, by introducing midwifery, maternal and newborn morbidity and mortality reduces. Shift from fragmented care to skilled and compassionate and woman-centric care. So the care becomes more woman-centric. We ask her, what would you like to do? How would you like to proceed? We are respecting her. We are allowing her to have somebody by her side. All women are actually anxious when they get into labor. Having someone close to her helps her gain more confidence, reduces unnecessary medical interventions, and empowers midwives as frontline workers, frontline leaders. Every time, we learn a lot in obstetrics. We learn OBG, we learn from the textbook Datta. We learn quite a lot of what doctors learn. But how capable are we to take decisions? How capable are we to lead? When you train to be a midwife, they instill in you qualities which would help you to make decisions, plus there is a legal framework to support you. Of course, when you finish your master's in obstetrics, there is no legal framework for you to be supported. Here, you have a legal framework to also support you, saying that this is your scope of work. So in that way, you are more confident, you become a leader, you can take up initiative. And aligns with WHO and ICM guidelines for safer maternal health leaders. That's what WHO says, that's what ICM says, that we should have more frontline maternal health leaders. So now if you look at this statistics, a Cochrane review. So a Cochrane review is basically a very, very high quality review of good randomized control trials. Meta-analysis and meta-synthesis is done, and data is collected from studies which are done really in a very high quality environment. And it shows that a midwife-led continuity of care can result in 24% reduction in preterm birth, a significant reduction in episiotomy, instrumental birth, or use of pain relief, while increasing psychological support of women. So this was published in the Lancet series of Midwives, which said that complications are lesser. Instrumental births are lesser, no vacuum, no forceps, sometimes no episiotomy. The mother gets to deliver in a position that she is comfortable. Normally in a ward and labor room, a woman is asked to lie down in a lithotomy position. But is that position actually supportive of delivery? When you stand, by gravity, something should come down. You make the woman lie down with her legs up and expect her to deliver, it becomes a little difficult. So in midwifery, we look at alternate birthing positions. We think about different breathing techniques, different support systems to help the mother deliver normally. So I think you should all remember that midwifery-led care units have resulted in 24% reduction in preterm birth. And I think we should all take up midwifery courses and become midwives. So these are some important facts of midwifery that you should actually remember. So, of course, there were certain institutions in West Bengal, Gujarat, and Andhra Pradesh. I think you would have heard of Fernandez Hospital. So they were hospitals who started this full midwifery initiative way before the government thought about it. And then these models were really successful. And after which in 2018, JAPIGO, BMGF, and the government sat together and drafted a guideline to initiate midwifery. And the plan was to roll out midwifery in the year 2019-2020. So this nurse practitioner midwives had to be trained in a particular place called as State Midwifery Training Institute. Okay, so that was the plan. And initially the government thought that we should have 6 national midwifery training institutes and they would be able to train the midwifery educators. So this has 2 components. We have nurse practitioner midwives and we have nurse practitioner midwifery educators. So the nurse practitioner midwives need to finish BSc nursing or GNM nursing, work for 2 years in an OBG unit where they have deliveries, antenatal care, postnatal care, and then they take up this NPM course, which basically happens in state midwifery training centers, institutes. In UP, do we have this training happening? In UP, do we have this training happening? My students, are you aware? Yeah, it is happening. It is happening in Meerut, it is happening in Kanpur, it is happening in Lucknow. Okay? Then the nurse practitioner midwifery educators. So for this, what you need to do is you can be a BSc nurse or you can be an MSc nurse, after which you should go for a 6 months training course, which is basically at a National Midwifery Training Institute. It is a residential course. So you do the course and after which for 1 year you should go to the State Midwifery Training Institute and mentor a nurse practitioner midwife. After which you are certified as a NPME, Nurse Practitioner Midwifery Educators. So the Nurse Practitioner Midwife course is for 18 months. The NPME course is a BSc or MSc, and after which you do a 6 months course and you have to mentor nurse practitioner midwives at the State Midwifery Training Institutes. On this March 8th, on Women's Day, actually a midwifery-led care unit was opened in Dufferin Hospital in Kanpur Nagar. This is just information for you because we all belong to the state of UP. So, yeah. So this is the training cascade. We have recruitment of midwifery educators by state governments. So some of them are deputed, some of them are people who voluntarily say, I'm interested in this. Then we train these midwifery educators at the National Midwifery Training Institute for 6 months. The midwifery educators who qualify are posted in the State Midwifery Training Institute. One more beautiful thing about this course is this is not just like a theory exam and practical exam. They have competency-based assessment to see whether the midwives actually are competent to do what they are supposed to do. After which, training of the NPM trainees by midwifery educators should be done for 18 months and the size of the batch is 30 and the number of batches per year is 1 batch. The midwifery educators are mentored by the NMTI mentors and external observers. They will be supported. And the trained NPMs are deployed at Lux certified facilities. Okay? That is the labor room quality initiative facilities. And trained NPMs are mentored by midwifery educators. So the midwifery educators support the NPMs. Okay? And they are posted at the Lux facilities, certified facilities. So in UP, actually speaking, a working group committee has been established. It is under NHM, and I think UPSMF has provided permanent registration for 5 NPMEs of the UP batch. UPSMF conducted the examination of the first batch of midwifery educators in 1st of May 2024. NMEs, that is nurse midwifery educators, have been deployed in identified state midwifery training institutes of Kanpur and Lucknow. The training of the first batch of NPMs, that is 30 of them, have been selected from Lucknow, and midwifery-led antenatal services are happening at 3 facilities, Lucknow, Meerut, and Kanpur. And there is an MLCU in Meerut, that is midwifery-led care unit. Okay, they are units where they can work. And recently, there is a new MLCU which is established in Kanpur Nagar, which is the Dufferin Hospital. Okay. So now let us see what is the role of midwives in improving the healthcare outcomes. So the first role is to enhance the quality of services or quality of care. I think all of us like a doctor, a physician, or anyone who spends a lot of time with us. Half of our issues are in our mind. If the doctor takes 2 minutes to see us, we don't feel very happy. He may be the best doctor, he may prescribe the best medication, your illness may be cured within 5 days or 3 days. But if the doctor doesn't spend time with you, you don't feel all that confident about the doctor's abilities. Half of our illnesses are in our head. So when we have a nurse practitioner midwife, she spends a lot of time. She listens to a lot of the patient's concerns, lot about her culture, lot about her family, lot about her income status. So she basically has a holistic perspective of the woman, and she is with the woman from the beginning till the end. So there surely would be an enhanced quality of care. There would be improved maternal and neonatal health outcomes because we are going the natural way. Lot of safe birth practices are promoted. We try and let the mother deliver normally. The mortality rates are less, and patient satisfaction and quality of care is enhanced. So let me give you some examples from our midwifery-led care units and our midwifery services from the state of UP. So in Uttar Pradesh, 92% of women in early labor were offered non-pharmacological pain relief measures in our antenatal care services, in our midwifery-led care units. 92%. They did not give them medications. They gave them non-pharmacological pain relief measures. 89% of the women were encouraged to walk during the first stage of labor. When you walk, labor will progress very efficiently. And 98% of the newborns were breastfed within 1 hour of birth, which is very good, which is a good number. And 100% mothers received a uterotonic immediately after birth. When you use a uterotonic, the chances of PPH and other complications are lesser. So these are the service statistics. Midwives have conducted about 3,389 ANC OPDs, which is a good number. Midwives have conducted 351 births till March 24 at Meerut. Out of all the births conducted by the midwives, 85% of births, women chose alternate positions, not the supine position, and semi-sitting position was a position that was preferred by all women. Experience of majority of the women, that is 66% of them, were good. They felt very good having met a midwife, and the remaining said it was 34% of them said it was average. Furthermore, 87% of the women said we would love to come back to the midwife. All of us, when we think of getting married, we all think of, going to good hospitals, meeting good doctors, but midwives is a new new strategy, and I think we should go to, midwives as well. Yeah. So whenever we make policies in midwifery, things that we need to remember is establish an educational framework at the national and state levels, which has already been done. Ensure evidence generation and knowledge management. Whatever measures we follow, whatever alternative and complementary therapies we use should have evidence base to support them, and facilitate creation of a favorable policy and regulatory environment. If the government, if the top management doesn't support us, if we don't give jobs to nurse practitioner midwives, no one is going to take the course. So these things should be kept in mind. And whenever policy is being made, look at evidence-based practice, look at all the regulations and standards of care, look at the training and education that the educators get and also the nurse practitioner midwives get, and also see to that this particular unit covers a lot of access to care and equity. Like the rich and the poor should be able to be treated in the same line, the same quality of care should be provided. Okay. And there could be a lot of evidence-based policies in midwifery around home birth policies. So wherein we create, because a mother will be more comfortable in a home environment, benefits and safety of midwife-led home births, informed consent and shared decision making and not autocratic decision making, importance of educating and involving women in care decisions, good postnatal care, support for breastfeeding, mental health and recovery of a mother after delivery, cesarean section reduction. Every hospital cesarean section rate is higher. Policy promoting safe vaginal practices and promotion of various birth positions. There should be, for this to happen, there should be a lot of collaboration between our different medical fraternity members. The doctor should accept it, the system should accept it, and this should be integrated into our healthcare system. If it just happens in 2 or 3 private facilities, it's not going to take roots. It should be integrated within our healthcare system, just like Ayurveda, Unani, and Siddha are part of our healthcare system. And we should be able to work very well with the obstetricians, pediatricians, and other healthcare professionals, because there may be complications, there may be doubts that you want to ask someone. If the doctor, or the obstetrician, or the pediatrician there does not support you, it will become a problem. But though this particular model has a lot of benefits, there are a lot of challenges affecting the success of midwifery in India. So a few of them are role clarity of NPM and their integration into the existing healthcare system. Do we have posts to take NPM? Like we have staff nurse post, nurse tutor post, assistant professor post. We do not have a separate cadre. Of course, it has been started, but not many people are taking it up. So that is a problem. Career progression. If we are not getting jobs, why will we take a job? We need to, at the end of the day, all of us work for money. Of course, passion is there, desire to serve the community is there, but primarily without money, you cannot move forward. So if you don't have jobs, why will I take up a course? There should be legal protection. Actually, nurse practitioner midwives have a lot of legal protection for procedures. For administering drugs, there is a little bit of problem. I mean, they have to get permission from the Drug Advisory Board. It is still in process, so that has to be taken care of. The midwife should be trained properly. For that, we need support from the doctors, the obstetricians, and other midwives. Sometimes in India, we do not have good midwives. We need to get midwives from abroad to support the education of our midwives here. Cultural and societal barriers. We all want to go to the top obstetrician for delivery. Nobody is thinking of a midwife. She's a nurse. She may not know. Regulatory and institutional barriers. We may not be having support from the government for us to take it forward, and resource limitations. So how can we overcome these challenges? The first thing is educating everyone. I mean, I stand in a hall with a lot of nurses. Y'all are nurse educators, nurse administrators, nursing students, undergraduate and postgraduate. But not many of us had an idea of, who a nurse practitioner midwife is, how is she different from an obstetrician. So I think educating all of ourselves about the availability of this course, what is the scope of work is important. Advocating to people who are sitting on top, our policy makers, principal secretary, our councils, everywhere around would make this, and pushing for this course makes it better. Public awareness campaigns, professional advocacy is something that we should do. Collaboration, please speak to other doctors, ask for their inputs, involve them in our particular midwifery course. And increasing investment, we should offer more funds for this course. So more staff nurses from the government and the private are deputed for this course. So people would like to take it up, and securing funding for midwifery services and infrastructure. Because to set up a midwifery-led care unit, we need separate infrastructure. We need separate equipments and instruments to help with the natural process of delivery. Yeah? So all this has to be facilitated by good funds. So to conclude, I would like to say that it is very important to have evidence-based policies in improving maternal and neonatal health, because there is a 24% reduction in complications with having a midwife around. Midwifery's critical role in reducing risks and promoting healthy outcomes is quite important. And we need a lot of further policy development, research, and investment in midwifery care, because we need to work on it, develop it, and tailor it to the needs of our country. And I think in all the developed nations, midwifery is a booming area, and everyone goes to a midwife in comparison to a obstetrician. So I'm done with the presentation. Thank you. Do you have any questions? So if you don't have questions, probably you understood everything, or you didn't understand anything. Yes, ma'am.
So very excellently delivered a session on awareness. I'm very sure the final year students have a lot of learnings. I wish to just state that way back 45 years ago, I did my general nursing, I did my midwifery. That was the starting of my career. We had a 1 year long midwifery that was in the Indian Navy, and we nursing officers managed the entire setup of deliveries, whether a priming gravida or a multi-gravida. We never had an obstetrician in the LDR whatsoever. Yes. They were on a call, and if we felt there are anticipated complications, we would call them. I'm talking of 1977, 78, 79, 80, and this continued for multiple years in the Indian Army setup. Even now they are privileged because they take midwifery in the Army education, a 1 year long program. They are privileged and they are also protected. Yes. And they have the obstetrician for intervention just a phone call away. So somewhere in the private sector, this privileging empowerment has been missed out. In the private, the entire obstetric, simplest of the work, which is a nature's work, has been hijacked by the obstetricians because they can charge a huge amount of money for even a normal delivery, which costs 1 to 1.5 lakhs for a patient, a normal delivery. So I think somewhere this scenario has to change. There are so many good examples in our country where this is working, and with nurse practitioner in midwifery, the privileging is also there. Probably the country has to wake up to this call. The doctors have so much more advanced work to do. Yes. They don't need to just stick to the normal delivery or obstetric work, antepartum time, intrapartum time, and the postpartum. All that can be managed by the midwifery experts. That's all I wanted to say.
Thank you, ma'am. And I think there are some places in India also where OBG nurses still conduct deliveries. They do everything. Only if it is abnormal, they call doctors. Like they just have their regular BSc nursing or masters and they still conduct.
Entire Indian army practices
This is that.
Entire, yeah. And I have conducted more than 500 deliveries as a very young nurse. So I think there is no big deal. It is only the empowerment, the privileging, and the legal protection, medical legal protection, which needs to be given. The rest should be in order. Thank you.
Thank you, ma'am.
Thank you for such an informative session, ma'am. Now I would like Sister Maggie Jose, ma'am, to kindly provide the valuable feedback.
Good afternoon to all. First of all, I acknowledge that I forgot, I think I was embarrassed. I could not speak about Ms. Dr. Monica, about her biodata, I forgot completely. Because I told something about the leader and I knew her personally. So I know she is a very good leader and she had been leading us. So I just got out of it. When I was sitting there, I remembered I have not spoken anything about her. I think all of you must have also felt that. So it was a blessing in disguise, so I will be just saying about her a little bit because the audience may not know about her. I'm sorry for not explaining.
It's okay, sister. No problem.
Will you please speak? Dr. Monica Rita Hendricks currently serving as Senior Program Officer at UP State Medical Faculty and Jepaigo, Johns Hopkins University affiliate. Education, ma'am holds a PhD from Sri Ramachandra Institute, Chennai, focusing on neurodevelopmental outcomes in preterm neonates. She earned her master's and bachelor's in nursing from St. John's College, Bangalore. Experience, she has previously held key roles including associate professor, nurse quality coordinator, and consultant at BEMPU Health. Her expertise is reinforced by multiple certifications in bioethics, pain management, and quality improvement. She has many achievements and active contributor to education and research. Ma'am has guided numerous projects, conducted in-service training, and presented at national and international conferences. She has also organized major healthcare conferences, including the 5th National Kangaroo Mother Care Conference 2021 and OSCE Master Training Workshops 2024. Her leadership continues to shape maternal and neonatal health care. So I think let us put our hands together to give ma'am a very good round of applause. It was really an enriching and a brainstorming session. I think many of us will agree that it was a revision for many of us. It was like a tutorial session which gave us lots of information regarding midwifery and what is a midwife and who is an obstetrician. The difference she has explicitly explained to all of us, and she has explained the scope for a midwife, how she can be functioning as a self-independent person, and what is the role of NPMS. So all those things are very clearly explained to us, and I think many of you must be having in your minds, maybe I can, after this particular study, I may get into that so that I can work independently with the help of others, but then at the same time, I can be a good midwife, caring for the mothers or the women-centered care, and thereby reducing the maternal as well as the neonatal mortality rates. And she has also explained about what is the role, what are the strategies that is necessary to bring about that care in our curriculum. So once again, thank you so much, ma'am, for your brainstorming, dynamic and vibrant presentation, which gave us lots of input, and we hope we will continue to practice, take care of our patients, because we had already morning 2 sessions. One was on related with empathy and human touch, and followed by that we had the technology developmental programs, the simulation-based training. So everything is there available for us, but our human touch and then our empathy to patient care is very, very essential, and she has given us one more input session on regarding that. So how we can help young mothers to have their deliveries safely conducted and how they can be helped, how the healthcare facilities can be improved, how equitable services can be brought about in the both regions, the urban as well as the rural areas. She was also telling about 80% of the population lives in the rural areas and only 20% lives in the sophisticated areas. But our role is to develop those people who are living in the remotest villages where 80% of the population is centered upon. So let us as nurses work towards improving the health status of women and children in our respective areas. Thank you.
Thank you, ma'am. I would like Mrs. Anamika Chaurasia, ma'am, to kindly come up the stage and present our esteemed speakers and chairperson, the memento. Thank you, ma'am. So as we move ahead with our fourth plenary session, this session presents another opportunity to gain deep insights into the topic, innovative training and education for midwives. We are privileged to have with us Dr. Anjalaji ma'am as the chairperson for this session. I cordially invite you on the stage, ma'am. So Professor Dr. Anjalaji ma'am, she currently serves as Professor Vice Principal cum Nursing Superintendent at Era College of Nursing, Lucknow. Ma'am has a PhD in Nursing from RKDF College of Nursing, Bhopal. She holds an MSc Nursing, Community Health Nursing from KTG College of Nursing, Bangalore under RGUHS. An MDM from Indian Cell Therapy Institute, Madurai. PGDHM from Board of Academic and Executive Council, Chennai. And MA in Sociology from Swami Vivekanand Shubhurti University, Meerut, Noida, and a BSc Nursing from KMCH College of Nursing. The ma'am has over 2 decades of experience in nursing education and administration, starting as a lecturer cum clinical instructor at Narayana College of Nursing, Vellore, followed by a ward in charge in EMR casualty at AVMCH, Puducherry. Later, she served as a lecturer at KTG College of Nursing, Bangalore, Eras College of Nursing, Lucknow, Assistant Professor, Associate Professor, Nursing Superintendent at ELMCH, Era University, and Vice Principal since 2017 and Professor. Ma'am has actively participated in over 30 national and international conferences, workshops, and seminars, including serving as a resource person, moderator, and co-scientific secretary for various nursing and healthcare-related events. Ma'am have guided and published multiple research studies in national and international journals covering topics such as kangaroo mother care, basic life support, essential newborn care, insulin administration, fertility factors, and Pradhan Mantri Jan Arogya Yojana utilization. Ma'am has organized college programs, workshops, staff development programs, and participated in community health initiatives like pulse polio, immunization, AIDS awareness, and STD camps, and have a strong foundation in statistics and research. Ma'am holds lifetime membership in various professional bodies including UIJIR, CNRS, International Researcher, NSS, INSC, GLP, and AHA per ERA University, Lucknow. Ma'am has excelled in healthcare, education, leadership, research, and social impact, earning prestigious awards like the Astor Global Nursing Award, Best Teaching Award, Indian Women Leadership Award, Prestigious Scientist Award, and Bharat Gaurav Samman. Her contributions have gained national and international recognitions, including the Icon of Asia Award and Universal Hall of Fame record, showcasing their outstanding impact across multiple fields. Ma'am has also made significant contributions to nursing, healthcare, and education through multiple published books, research papers, and book chapters. Her notable works include Role and Responsibilities of HCP, Community Procedure Book, Manual Record for PBBSC, and Current Trends in Infection Control Safety and Prevention. Several chapters have been published in academic books on nursing education, infection control, communication and management, microbiology, and nursing informatics. Publications span national and international platforms with ISBN, ISSN registrations from reputable publishers. Additionally, multiple works are under process covering topics like nutrition, emergency drugs, hospital services, and healthcare instruments, further strengthening her academic and research portfolio. To join Ma'am, I would like our distinguished speaker, Ms. Karen Drayton Ma'am, to kindly join us on this stage. Oh, okay, so Ma'am is already here on the stage. Sorry, I didn't notice. I would like Mrs. Pragya Singh Ma'am to kindly come up this stage and formally welcome both our chairperson and speaker of this session. Now I would like Dr. Anjalachi Ma'am to formally introduce our speaker, Ma'am.
Happy afternoon to all. How are you all? Are you happy for today? Because we had a lot of expert, because even we can try, we won't get this type of lecture from anywhere. So what we, inside only we can expose always for 3 year, 4 year like that. So it's a good chance, you all proud to be today, and you had a lucky principal, and she was coordinated with everyone. She was carried out the nice conference. At the same time, you got the opportunity to meet various of leading hospitals and head and principal, everything. You will be created for your future opportunity too. So thanks to Dr. Deepthi Ma for giving and arranging this opportunity. Happy morning to all the dignitaries on the dais and audience. It's a very proud to be present today as a chairperson here, and we need to be speak about the midwifery. So what is any idea for midwifery? Already from morning we saw. What is midwife? So mid means what is the middle? What is wife? Already if in every human life, wife means it's throughout. Everybody commonly think it's take care of the family. It's right? If any girls started for marry, immediately the mother-in-law, father-in-law, everybody said, I can hand it over all the responsibility to her. So that means it's a wife. So midwife means middle of the life journey. Everyone took the birth and death, but the middle of the journey we are cross, lot of changes, lot of task and lot of responsibility to lead for your life. So based on that, from morning we saw already how we can lead for the midwifery, that is the education, policy, training, standard. What are the skills we can apply on this, we saw. Now we can see Mrs. Korean ma'am, how she will be teach innovative based on this to lead for our career. So now I am going to welcome for our Miss Korean ma'am has been nurse and midwife in the UK since 1999. She holds advanced diploma in nursing and BSc Honours in midwifery studies, working in 4 different hospitals in England, and she also provides period of emergency obstetric nurse training, work in 3 countries, Bangladesh, Kenya and South Africa. Between May 22 and December 23, she worked in Jabaygo in Wardha and Maharashtra, Jabalpur, Madhya Pradesh in the Government of India program associated. She has become the nurse practitioner and midwife educator trainer as an international midwife educator. She is currently working for CEL Community Empowerment Lab and research implementation on maternal and newborn care in Lucknow, Varanasi, UP. So first we can be proud for human being, because how many natures are there, creatures are there, any idea? Any idea? Creatures. There are more than 18,000 creatures are there in the earth. Out of this, we have the lucky of human. So we should be proud. In this, we have only 6 senses. Remaining or having 5 only. But they will be, every person took birth and death. But we have the special to have something in the society, to create something, to take care of your responsibility. As that, Mrs. Korean ma'am took responsibility to change the developing country of India. So we all together put the hands to welcome her dedicated service in midwifery and training sessions. Welcome you, ma'am.
Thank you so much for your welcome. My name is Karen and I come from the UK, but I am very lucky to be working in India now, because everyone in India, they are so welcoming. So everybody is always looking out for me. Are you okay? Can you wear a sari okay? You need this food, you need some drink. Everybody looks after me. So thank you for your welcome in India. I have been here nearly 3 years now, and I have learned a lot about childbirth in India. So this is what we are going to be looking at. But first of all, I would like to know something about you all. So if you are a first year nurse, can you put up your hand? First years, any first years here? No? Second years? I'm also testing whether you understand my English, actually. Second years are over there, well done. Any third years? Lovely. And you have 4th years also? MSc? Lovely. So welcome to this conference, and thank you for welcoming me. I have one more question. Well, I have lots of questions. If you know only one language, you can put up your hand. One language, you can put up your hand. So this is only me. Anybody knows 2 languages? 3? 4? 5? Indians are amazing. You know so many languages and you can communicate so well. What I would like to know next is, would anybody like to share with me, why did you become a nurse? Why did you become a nurse? So, I'm sure you have many stories, My mother was a nurse and a midwife, so for many years I did not want to be a nurse. I did everything else except being a nurse. But then I thought, let me try and be a nurse. And since then, I was very happy. So in this photo, am I looking excited? I look excited? This is because I'm a midwife, because I get to see so many babies. I get to see so many women who are so happy because they had a baby. I get to be with a woman while she's having a baby, and I can see the joy on her face. And it's a very special time of your life when a new life comes into the world. So I'm very privileged to be a midwife. So this is one of the babies that was born with me. So what do you think the baby is feeling? What do you think it's thinking? And will it grow and thrive? So this baby has just been born, but in India, the statistics for baby deaths are very high. In UP especially, the neonatal mortality rate is 36 per 1,000. 36 babies out of every 1,000 die, either stillbirths or neonatal deaths. Of these 36 babies, 39% die of birth asphyxia. So for me, this means the birth process is not good. Why is the baby being asphyxiated before it even starts life? This is not normal. So while I've been working with the Community Empowerment Lab, we have been looking at all the reasons why babies die. Why do they die in labor, after labor, and within the first month after birth? So while we are thinking about what the baby is thinking, we'll just watch a video, and if you like to close your eyes and listen, and we can feel what the baby is thinking. I have to press?
आप सभी को मेरा नमस्कार। खासकर हम कभी बहुत ही मुश्किल में हों या बहुत बीमार हों तो हमारे मुंह से सबसे पहला जो शब्द निकलता है वो है माँ। और अब हम एक नवजात शिशु के लिए उसकी माँ क्या है ये जानने के लिए हम खुद अब अपनी माँ के गर्भ में प्रवेश करेंगे। तो आप ये सोचने की कोशिश करें कि आप अपनी माँ के गर्भ में वापस आ चुके हैं। आप अपनी माँ के गर्भ में हैं, बहुत ही सुरक्षित और सहज महसूस कर रहे हैं। आप पहले एक कोशिका थे, केवल एक ही कोशिका, और अब 8 महीने हो चुके हैं और आपका शरीर देखते ही देखते एक कोशिका से कई करोड़ों कोशिकाओं में बदल चुका है और उसने एक नया रूप ले लिया है। और ये पूरी प्रक्रिया एक कोशिका से लेकर एक जीव तक की प्रक्रिया, ये सब आपके माँ के गर्भ में ही आपके साथ हो रही थी। आप और कुछ दुनिया के बारे में नहीं जानते हैं, केवल आप अपनी माँ, उसके दिल की धड़कन और उसके गर्भ को ही जानते हैं और उन्हें ही महसूस करते हुए आपने जीवन के अभी तक के क्षण गुजारे हैं। और आपके जीवन में, आपके शरीर में इतने बदलाव आए, एक कोशिका से लेकर एक जीव बनने तक, बहुत से अनगिनत बदलाव आपके शरीर में आए, और इन सभी बदलावों के लिए आपको खुद से कुछ भी नहीं करना पड़ा, कुछ भी आपको यत्न नहीं करना पड़ा, कोई भी आपको परेशानी नहीं हुई। ये सब अपने आप आपके माँ के गर्भ में आपके साथ हो रहा था। आपको कुछ भी परेशानी, कुछ भी दिक्कत महसूस
every newborn baby. But will this baby survive the next 28 days? There are so many reasons why it won't survive. So we've been looking at all the reasons how we can improve neonatal outcomes. So first of all, antenatally, we need to look after the mother. Too often I have heard that the mother-in-law is not feeding the daughter-in-law. The mother is the last person in the family to get any food. Her diet is less than anybody's, and yet she needs more protein. She needs iron, she needs immunizations against tetanus, and she needs calcium. She needs to be stress-free, not worrying about anything. We need her to register the pregnancy early. Then we can see, has she got any high risk factors? Should we be referring her to the doctor? Should we be giving her extra blood pressure checks? Should we be checking her for sepsis? She also needs to be aware of the danger signs, and not only her community and her family. Too often people are so delayed when they come to the health facility. Oh, I was having some bleeding, but I thought maybe it will stop. Oh, my head was banging with a headache, and my eyes had lots of visual disturbances, but still, I didn't want to bother anybody. So we need to encourage women and their families to know what are the danger signs and when they should come to the hospital. Then we can treat them, and then the baby will have a better chance of survival. They also need to be aware of the benefits. The government has provided many benefits to try and improve maternity and child health. Some people in the very rural areas, they do not know what these are. So if we do not communicate, they will not hear about these. They will not take advantage, and they will become even poorer. Birth preparedness. I'm sure you all have lots of lectures on all these things. Birth preparedness is being aware that you need some transport. You might need some extra money to get somewhere. You might go to one health facility, they might want to refer you to the next one. You need to be mentally prepared. You need to be physically prepared to bring some clean cloths in. Where I work in CHC Cholapur in Varanasi district, the mothers, they bring in dirty cloths. For a brand new baby, this baby will get sepsis unless they bring in beautiful, soft, clean clothes. So these, you know all about these, the Government of India initiatives that have been going on to try and include everybody in the programs for health. So at the bottom you can see the guidelines of midwifery services. So Dr. Monica was speaking all about this from Jopaigo's point of view, and I was working with Jopaigo for this program for 2 years. So I think in India and around the world, we treat a pregnant woman like a robot. We don't see her as individual. We don't give her empathy like she needs. We don't look at her history. Her history will be different. Every single person will have a different history, different concerns. And we need to listen and find out what is that history in order to be able to provide good care. So if we look at physiology rather than looking at the person like a machine, then we will be able to do birth better. But there are so many reasons in India why people find it impossible to do physiological birth. The evidence shows that up to 90% of labours are induced with oxytocin or misoprostol. And I have seen it myself. I've been to at least 15, 20 hospitals. No one will admit to it, but it is happening. You will all learn oxytocin is bad before delivery, but everyone is doing it. So this morning, I want to encourage you to do what is right. Even though it will be a problem for you, you need to stand up for what is right and what is good for the woman. So labour needs time and space and respectful maternity care. Dilatation takes time. Yes, everybody's in a hurry. The patient wants to hurry up. They don't want that pain for so long. The mother's family doesn't want it. The community doesn't want it. The doctors don't want it. And the nurses, everybody wants to speed up the labour. But if you do this, the baby gets asphyxiated because oxytocin makes the uterus contract more. So as the uterus is contracting, the baby gets squashed and there's no oxygen going to the baby. So in a normal labor, there's a squashing, and then there's relaxed. Squash, relax. If you do it too fast, the poor baby never gets a chance to breathe inside. The oxygen is not getting to the baby. So this is why we get 39% asphyxiated babies. Because the oxytocin is making the uterus contract too often, and it's not allowing the baby to recover in between contractions. So this is really bad unless we regulate it, unless we are trying to induce somebody gently. We have to monitor the fetal heart. How is the baby coping with the oxytocin? If it's not coping, we have to go for cesarean. So descent also needs time. Stretching needs time. How often do you see somebody going like this, trying to get the baby out? It doesn't help. And all it is very painful for the woman. And I never saw anybody do restitution. You all know the process of birth. How the baby comes down, it turns like this, comes out beautifully. But as soon as the head is out, people yank the baby out. And before they're yanking out, they're giving fundal pressure. And before fundal pressure, they say, oh, she is 8 centimeters dilated. Jor lagao, push the baby out. And then everybody's shouting, push, push, and this poor baby is, what's happening? And the fundal pressure is also terrible. So all these things we're doing just to hurry up the labor, when actually the woman has been pregnant for 9 months. So why should she deliver in 9 minutes? We need some time, right? For the baby to adjust from inside to outside. And then we need skin-to-skin time, 1 hour at least. Skin-to-skin helps breastfeeding. In UP, the breastfeeding rates within 1 hour is 24%. Only 24% of babies get breastfeeding within 1 hour. This is terrible, and this adds to the deaths. If the babies are not fed early, they will die soon. And also, we found in the rural sub-centers, they want to go home immediately. They should stay for 24 hours to rest, to see if there will be a PPH. We can give them lots of advice about what is good to do postnatally. But no, they love to go home and have their own problems without help. So, I have a program called Beautiful Births in Varanasi. We are trying to promote beautiful births. They are gentle, they are physiological, and mothers are happy and the babies are happy. So we don't do any routine interventions. No inductions unless necessary. No routine episiotomies. Because if you wait, the body stretches up. We don't need to cut the woman, even for primies. It will stretch if we give it time, if we are not doing fundal pressure. We don't need to do episiotomies. In my life, in 20 years in the UK, I have done about 6 episiotomies. And I work in labour room all the time. So we don't need to do them all the time. And where I work in Varanasi, the nurses there have seen, wow, we don't need to do episiotomies. And it's quicker because now we don't need to suture. So this is one thing we can try and do. We should only do vaginal examinations every 4 hours. I was in one medical college. A woman was there. The doctors came in. 4 doctors in 5 minutes did a PV. Not one had consent. Nobody explained to the woman. And they just did the VE and they didn't communicate between themselves. Is this a good thing for the woman? It's terrible, isn't it, right? So we need to stick up for that woman. We need to support her human rights also. And we can always point to evidence-based care, 4 hourly. Obviously, if you're trying to teach, then teach somebody properly. Ask the woman, then do it, and then say, what can you feel? And learn from it. So they don't all have to go like this. All inserting their fingers and making infection. We can use a partograph to see if it's taking too long. We can encourage mobilization in labor, upright positions for birth, and non-pharmacological means of pain relief. So this woman This was the JPIGO program that we heard about last session. These are the two NPMAs, nurse practitioner, midwife, educators. The woman is upright. It's her first baby. She's sitting on a birthing stool. She has 2 birth companions, and we are having fun. You think we can have fun in labor? We can have fun. It is good. We can chat about their family, what is happening, and the whole experience can be beautiful. So the impact of physiological birth. For me, the best impact, the mother is smiling. She gave birth. She had so much pain, but as soon as that baby's born, she will say, oh, it's not that bad. That pain was bad, but now I can forget it, and the baby is beautiful. So the recovery is quicker, much better than cesarean. There's less blood loss, early breastfeeding, and maternal bonding, and self-esteem. All psychological things make the woman feel better. So what about this baby? This baby is distressed and not happy. So this is a lady. We are trying upright positions, even within the current system of labor rooms. So we can say, oh, there's no room to do upright positions. But we can monitor the baby's heartbeat, and this woman is very comfortable in squatting position. She's actually smiling, and 5 minutes later, she gave birth. Even I was amazed how fast just sitting her up did. She was so happy. So physiological birth makes use of hormones in labor. So if you see the medical textbooks, they're this thick, right? A medical book is so fat. So I'm looking for normal birth. It is 3 pages. And yet, normal birth can be, it doesn't have to be all pathological. This is the important part, is just the 3 sheets. And yet we just think it's all about medical problems and pathology and what can be wrong with a woman. Why don't we think maybe everything is okay? So there are lots of hormones in labor: oxytocin, beta endorphins, relaxin, melatonin, prolactin. You know all about these. We know what oxytocin does. Let me use this one. Hello? Is it okay? So we can use oxytocin enhancers. So what makes oxytocin flow better is if everybody is calm and confident, no smoking, no shouting and going on. If there are positive expectations, the woman is feeling safe. Say, it's okay, you're having pain, but it's normal. We'll be with you, we will support you. So this is what midwives do. We can give massage, we can give warm water compresses, we can laugh with them, and then they forget they're in so much pain. These are just simple things. But nowadays, we love high technology and the support of birth companions and everything. I lost my thing. So beta endorphins, they also help the woman feel less discomfort and pain. Relaxin helps you to relax. Melatonin also comes if we leave the woman alone, if we don't stress her out. Prolactin is connected to breastfeeding, increases during pregnancy, increases breast milk production, and ejection of breast milk when the baby starts sucking. So all those things help the baby to feed well and to become a successfully healthy baby. Whereas the hormones and chemicals that slow down birthing are adrenaline. You know, when you're stressed, your adrenaline levels go up. When there's lots of noise and you don't know what's going on and nobody's talking to you and everybody's shouting at you, this is when you get stressed, and this blocks the oxytocin and the endorphins and the relaxin. And catecholamines, they also increase stress. So physiologically, all these things are going on in your body. As nurses and midwives, we need to work with that woman, not against the woman. So therefore, we have a duty to provide that kind of environment. We don't can't keep saying all the excuses, oh, we don't have time, we don't have room. Who decides how much room a birthing woman needs? We can say, let's change things a bit. So in our Beautiful Births program, we try and advocate for evidence-based practices. And then when the baby's born, we try and keep them skin to skin for all the advantages of that. And we try and avoid oxytocin and misoprostol. We never do fundal pressure. This can cause so many problems to the mother. Why I took this picture was, above every birthing woman there is a poster. It says no fundal pressure. But I have seen so many people do fundal pressure like CPR. They sit on the woman's head and they give fundal pressure. Whatever is on the walls is not what they are doing. And then this baby might have shoulder dystocia, nerve damage, and it will be stressed in addition to the oxytocin stress. Episiotomy by the World Health Organization is not recommended. There are only a few cases when we should do episiotomies. If it's complicated vaginal birth, such as breech, shoulder dystocia, if you're using forceps or vacuum, then we can do episiotomy. Or fetal distress. But people do episiotomies for no reason, because they haven't been monitoring the baby's heartbeat. So how do they know if the baby is stressed? So we need to do fetal heart rates. Is the baby distressed? And then we can deliver the baby. So this is the normal position of a woman when the baby is coming out. But why don't we do her upright? The baby's coming out this way, but how much more easy if the baby is trying to come when the woman is upright, squatting, or some other position. So we can try all these different positions. It doesn't take a lot of effort. Just ask them to stand rather than to lie on the bed, lithotomy position. These are in Jabalpur in our labor room. You can see how close together the beds are, and yet we're still getting chance to massage and to reassure the woman. We can use birth companions, and we can ask them to do exercises. So upright positions can reduce pain in labor and shorten labor times. And we can use lots of different positions. These two photos I showed you before, this is the birthing stool that we use. So people can support her from behind and give massage, and the midwives need to get in a different position to catch the baby. We can do semi-sitting, all fours, squatting, or sitting on a support. So these show the baby descending and rotating. Can you see the baby has turned? Turned a bit more. And now it's coming out. Coming out. Coming out. And then it turns to the side. So all babies need this restitution. No pulling the baby out. And then the baby comes out much more gently and less stressed. So for newborn care, immediate skin to skin, unhurried care, no maternal baby separation for 1 hour, and initiate breastfeeding immediately. And talk to the woman about everything about babies. New mothers, they don't know anything except what other people tell them. And as a health professional, you can tell them all the good things. Delayed cord clamping improves newborn hemoglobin levels. If we do immediate cord clamping, the baby is losing up to 1/3 of its blood supply. Let the blood go to the baby a bit more while it is adjusting to breathing in the air. Breastfeeding in the first golden hour. If you don't feed in the first hour, the risk of that baby's death is 1.3 times. So it's much more likely to die if you haven't breastfed it within 1 day. And it's amazing how these babies are not fed. You ask them, when did you last feed the baby? And they'll say, oh, I don't know, yesterday. And you think, but the baby was just born, it needs feeding every 3 to 4 hours. And respectful maternity care. I'm sure you know lots about this, that we need to look after the woman's rights and the woman's position, the woman's right to have a companion, and respect for where she comes from. So the Jupaigo talk talked about why does India need midwives? Because we have over 30 million pregnancies a year and we don't have enough staff. So we need to have more people just invested in midwifery and childcare. And 80% of preventable maternal deaths, stillbirths and neonatal deaths can be prevented. 86% can be prevented just by nurses doing midwifery care, being trained in midwifery practices and doing physiological births. So in India, the maternal mortality rate is 97, but within every state it's very different. So UP, it was 130. Neonatal mortality rate is 32 in UP, and I told you already about breastfeeding rates. So there's so many reasons. So my topic today was innovation in midwifery education. So this slide shows different methods of training midwives. So this one is nurse training. We go to college, then we go to the hospital, college, hospital, college, hospital. And this is how we learn, isn't it? We learn by in college, we learn the theory, and then we go to the hospital and learn practicals. And then when we finished, we go to all the different hospitals. Sometimes we go to the hospital again. So in the Jupaigo project, they decided that people need ongoing training. So it's not just one-off, you learned everything you needed in college. You need to keep learning. So after this, if you go to the Jupaigo or any other Government of India midwifery project, you have 3 weeks of college, and then you spend a lot of time in the hospital practicing doing physiological birth. Because women don't have the confidence to do births without oxytocin, without fundal pressure, without episiotomy. So we need to have confidence, and that's what this program does. Did I do it wrong? So then now I was working for Jupaigo for this program. Now I'm working for the Community Empowerment Lab. So this model is everybody is already in the hospitals. So one person goes to CHC and says, let's do something different. Let's make beautiful births. And we do one thing at a time. We say, let's not do oxytocin. Let's not do fundal pressure. Let's not do episiotomy. And then now the staff there, they are all happy to do beautiful births. Nobody does episiotomies unless there's a big need for it. Nobody does fundal pressure. We also send a community team to tell the community, don't ask for oxytocin, don't ask for fundal pressure. We will do nice, beautiful births in Cholapur. So people are coming from different districts, just come for a beautiful birth. Because women want to be treated nicely. They want to have a good birth. So this is the model that we're using at the moment, where we go from one to the next one. And then somebody from this one, maybe the A&Ms or the staff nurses, they will go here, and they also will share all the knowledge. And because in India there are so many health facilities, we need to spread the message about beautiful births as much as we can. So this is our innovative way of education, using nurses, additional training, and then going into the places where women are actually giving birth. So I'm coming to the end of my talk now. What do these women have in common? Do you know who these women are? Rani Lakshmibai, the middle one, is Princess Chandni, apparently. And this one on the right, Rani Durgavati, actually. So from Madhya Pradesh. But having been in so many states in India, every state has these wonderful people, right? So they are freedom fighters, and they are strong people just like you. They know what is right and they want to do it. So this is what I would like to encourage you today to do is, we know what is right for beautiful births. We know women have a right to a beautiful process to welcome their baby into the world. So we are all part of this. So I'm encouraging you to be freedom fighters. So this is one of our NPMEs. And she is also an inspiration. For 18 years, she delivered so many babies, even up to 20 babies in a day. And she came on our program in Wardam, Maharashtra, and she helped a woman give birth in a beautiful manner. And the woman said thank you to her. And she said, I have been a nurse for 18 years, and not one person has said thank you to me. And she cried, because it's the first time she felt satisfaction with her job, because she had been one of these shouting women and pushing women and demanding women and disrespectful women. But learning how to be a special person, she has changed and she is so satisfied. So let's make it possible. Service with a smile. Want to go. So thank you, that's it. I don't know why it's not going.
Thank you, ma'am, for this beautiful session on beautiful birth. I would like Dr. Anjalaji, ma'am, to kindly provide feedback.
Welcome back. I think all are enjoyed this session. I enjoyed a lot because madam was bringing out 99 to 2000 training period back to me. Because we were studied that time, we had for the semester system only. We also had 6 months for a midwifery, only one single subject. We was posted in... Then we were posted for various of training center, government hospital. And already ma'am, Binu ma'am said she was exposed for more than 500 delivery. We were exposed more than 2000 delivery, independently we carried out. And we was done all the work. So that's, I thought when I was listening madam name, she will be brought for the UK based stimulation training, she going to be displayed like that. But she come across totally for the lower level, how the person be happy in their life, birth to death. She brought easily. So that every person will always remember, from birth to death, we should remember middle of the level only. The same, the woman also bear their life. So she also have the empower, she must give the choice, she must have the select for the life, she can move everything. When we move like this, she definitely have without any complication for the normal birth. So we cannot give the chance to do like this. So always we will be say, this is a policy, this is a guidelines, you sit like that, you lay down like that, you stand like that, you will deliver like that, you cannot move, you cannot run like that. So all this restriction always goes for the difficulty of the women and in newborns. So based on that only we expose maternal mortality rate, and for the infant mortality rate, this will be increasing. So these preventions, we always go as a nicely, she was brought it from how ANC care, how the adolescents care, how we can go for ANC, how she was related in the, how the child can feel in the mother's womb, how it will be. Then how, what they listen, who's the exposure person, how badly she was carrying, how she will narrate it to the child. Everything she nicely explained in the video with the silent base. And she was working in this, all the government associations, wherever the person is not aware, that area as an educator, as a trainer, as a healthcare person, we should make them for more knowledge to get for all the facilities. And she was explained in the physiology way of how the mother can feel, how she can herself deliver, how she can care for mother as well as that, and cord clamming, newborn care, and importance of respectable maternity care. When Rosalie ma'am came for, she is a external accessor in our college. Ma'am was asking one MSc faculty, what is respectable maternity care? She can't able to say the answer. You can imagine where we are, the training and education, practice and skill as a MSc level. That means it's always need self-regulations. We as an institution will give the care, as an institution we teach you, training you, practice you. But every individual can realize yourself where you are standing, how you are performing, how much you are going to be work out through your professional dedication. That's very important. Based on that, ma'am was clearly explained where we will be there and how we should be goes. I request all to be there, always be with your skill and practice and knowledge. Right place you can invest and you can utilize. You can don't make any harm to anybody. If already you saw, other than human, most of the animal also giving birth. Anybody saw? A pakri and a buffalo and cat, like this you saw, na? Have you anybody is needed for that to deliver the baby? It's simply just for standing only it's giving. But what as a human we are making? We are making lay down, you can push it, you can massage it, you can turn it, you can give like this. So it's a nature also show us nothing to be impossible. In the word itself given is a possible, in impossible itself. That means everything will go for the normal process. As a human, we should be support and empower. We can make them to go lead to happy life. So thank you all. You can everyone, I think, will be practiced based on the madam knowledge. Thank you, Miss Korean ma'am, for giving nice way to narrated everything clearly and simple way. I think ma'am was completed full course with the answer key, everything in the slide share. Very important point she was explained. And the skill base she was explained. Thank you, ma'am. Thank you so much.
I request Mrs. Manisha David ma'am to kindly come up the stage and present the memento to our esteemed speaker and chairperson, please. of the event. And our esteemed speaker, Ms. Rania Lampu ma'am, has already joined us online. So before her session, I would like to briefly introduce her to you guys. So Ms. Rania Lampu ma'am is a distinguished global educator, STEM instructor, ICT teacher trainer, and researcher. She is currently serving at the Greek Ministry of Education's Directorate of Educational Technology and Innovation, where STEM projects for Greek schools are developed. Additionally, STEM instruction is provided at the Greek Astronomy and Space Company. Recognized with over 200 national and international awards, she has been honored as a Global Teacher Award winner 2019, 2020, and 2021 by AKS Awards, and was a Global Teacher Prize finalist 2019 by the Voke Foundation. Her achievements have been featured in Passion Vista as a Global Icon 2020, Fortune among the top 10 women entrepreneurs, and Global Trade Chamber's 100 most successful women in business. Further acknowledgements include mentions in 30 Shining Stars of the World, Queen's Book 2021 and 2022, and Hosna Global Women Book 2023 by Hosna Media Group. Thank you, and over to Ms. Rania Lampu ma'am.
Yes. Warm greetings from Athens, from Greece. Am I audible? Okay. I would like. Yes, thank you. I'm very honored and happy to be invited here today. I would like to extend my hearty congratulations to all organizers of Samarpan Institute of Nursing Paramedical Sciences. And of course, I want to thank you for the kind invitation. Today, I will focus on big data and nursing informatics. And as we gather here, I think we found ourselves under the section of innovation, technology, and compassionate care at the same time, all with one shared goal: to improve the lives of patients. So before starting share my presentation, I want to say that nurses have always been at the heart of healthcare. They're the advocates for patients, they are guardians of quality, the leaders in delivering care that is responsive to the individual. But today we see an exciting transformation with the ability to capture and analyze vast amounts of data from electronic health records, wearable devices, genomic data, and more. Nurses are now becoming key drivers of data-driven patient-centered care, and this is more than just technology. It's about harnessing data to make smarter decisions, offer personalized treatments, predict outcomes, and most importantly, improve the overall patient experience. So today we will dive into these innovations, we will explore the real-world applications and discuss how they are transforming everything from personalized care plans to population health management. So allow me to share my presentation. Unfortunately, I have to stick to 30 minutes. I don't know if it's visible now. Can you see also the change of slides? Okay, thank you. So the integration of vast amounts of healthcare data with informatic tools has allowed healthcare professionals to provide a more personalized, efficient, and effective care. And this transformation actually is transforming the way nurses approach patient care with a stronger focus on individualized care plans and improved outcomes. Nursing informatics is this specialty that combines nursing science, information management technology, and focuses on how nurses collect, analyze, and utilize data to improve patient outcomes. So nursing informatics professionals actually use data-driven technologies to enhance decision-making, to streamline clinical workflows, and foster better communication between patients and healthcare providers. Of course, the big data in healthcare refers to this amount of information collected from various sources, such as electronic health records or patient monitoring devices, wearable technologies, medical imaging, lab results, etc. So we're going to see one by one these key considerations. What about how we can enhance patient safety, patient engagement, empowerment, and of course, how we can improve our clinical decision making. At the same time, we will discuss about the challenges and considerations such as data overload, training, education, data privacy. The idea is to know the 5 V's, volume, the variety, diversity, velocity, veracity, and value of data, the massive amounts, the speed, the types, formats, the accuracy, and the relevance of data. So all these sources offer the massive amounts of data which come from different sources. And of course, the applications that we're going to see have to do with predictive analytics. We will discuss about this because now we can analyze large data sets of patient histories, and this can help us identify, for example, early warning signs of diseases, potentially improving preventive care. For example, predictive models can access the likelihood of developing chronic conditions such as diabetes or heart disease. More personalized medicine, for example, genomic data combined with clinical data, enables healthcare providers to design more effective and personalized treatment plans. The public health and disease, because big data now is used to track disease outbreaks and epidemics in real time by analyzing data from multiple sources such as social media, trends, travel patterns, and public health records. Of course, drug discovery, because pharmaceutical companies use now big data analytics to accelerate the discovery by identifying potential drug candidates, predicting drug effectiveness, understanding adverse effects. We can streamline healthcare process by analyzing the workflow, also data to identify inefficiencies, to optimize resource use, and of course, this way we can reduce the healthcare costs. So how does nursing informatics contribute to improving patient care? By enhancing, by providing actually real-time access to patient data, what we call evidence-based guidelines and clinical protocols, helping nurses make informed decisions. This actually reduces errors, speeds up the diagnosis, and ensures the application of the best practices in patient care. Improves patient safety because informatic systems such as electronic health records and medication management tools help minimize human errors, particularly in drug administration and treatment. Digital platforms enable efficient communication between healthcare teams, ensuring that patient information is updated and shared across departments seamlessly. And this, of course, reduces delays and misunderstandings that could negatively impact patient outcomes. By leveraging also data analytics, nurses can better understand patients' individual needs, their preferences, their health patterns, and this leads to more tailored care plans and reduces administrative burdens. Of course, the remote, I forgot to mention that now nursing informatics supports implementation of remote monitoring and telehealth services, enabling nurses to track patients' health data in real time and intervene early when it's necessary, especially for patients in rural or underserved areas. So we can collect, analyze data on patient outcomes. We can help healthcare organizations identify trends, areas of improvement, successful interventions, and this continuous feedback loop actually drives high standards of care and fosters innovation. So we call differences between traditional healthcare, data management, and the use of big data have to do with the data volume, the data variety, the velocity, the complexity, because now we deal with a much variety of data, with the data sharing, interoperability, with more regulatory and privacy concerns. Of course, now we utilize cloud-based or distributed storage systems that are highly scalable and can handle large volumes of data. So why is it the grace of technology critical in modern nursing practice? Because of all the cases that I mentioned before, we talk about managing complex conditions. Modern healthcare involves managing more chronic and complex conditions, which require care coordination. Technology helps nurses manage large volume of patient data, track care plans, and ensure continuity of care. Technology provides nurses with access to continuous professional development, through online courses, or simulations, virtual learning platforms. And this ensures that nurses remain up to date with the latest healthcare trends and clinical skills. Don't forget about the simulations that virtual reality and augmented reality technologies allow now for advanced simulations and clinical scenario training, improving nurse preparedness for real-world situations. Compliance documentation, because now electronic information records and other health information technologies make it easier to comply with legal and regulatory requirements by ensuring accurate documentation of patient care and automating reporting processes. So with the rise in data breaches, technology support healthcare organizations in safeguarding patient information through encryption, through access control, and secure communication systems, ensuring compliance with privacy regulations. How big data intersect in clinical settings? Very important to mention the clinical decision support systems, because nursing informatics actually integrates big data into the systems, providing nurses with evidence-based recommendations at the point of care. For instance, it suggests medication adjustments based on a patient's history, current medication, lab results, reducing human error, improving outcomes. It can help us using modeling. Big data nursing informatics can help identify patients at risk of sepsis or other complications. And these systems send alerts to nurses and healthcare providers, allowing immediate intervention. About the workforce management, because we can analyze the nurse workloads, staffing levels, and patient demand trends, leading to better scheduling and resource allocation. This ensures what? Ensures optimal nurse-to-patient ratios, minimizing burnout and improving care. And at the same time, nurse informatics can use data to predict the inventory needs, predicting medications or equipment, reducing waste, and ensuring that essential supplies are available when needed. This management, of course, of records has to do with comprehensive data integration across different healthcare systems. So real-time access to comprehensive patient data, improving care coordination, and improve what we call documentation accuracy. Because we enhance automated documentation, this allows nurses to spend more time with patients and less time on paperwork. So data from various clinical devices can be automatically integrated into these records for better accuracy. And this helps researchers also to analyze large data sets in order to identify patterns, outcomes, and best practices. And this contributes to evidence-based practice, ensuring what? Ensuring that clinical care evolves based on the latest findings. And also, we talk about population health management. Big data analytics allow nurses to track health trends at the population level. They can identify risk factors and at the same time implement preventive measures, especially for chronic diseases like diabetes or hypertension. And big data also enables nursing informatics systems to provide patients with customized educational resources on their medical conditions and history, improving patient understanding and self-management. We can track a patient's health, even remotely intervene when it's necessary. How big data helps nurses in providing personalized care? We talk about assessment. A nurse can use big data to assess a patient's risk of developing conditions based on their medical records. So gather and access comprehensive data on the patient's health, including the medical history, the genetic information, the lifestyle, environmental conditions. It's about real time, allowing for early detection. Then I mentioned about the predictive analytics. For example, for cancer patients, nurses can leverage predictive models that analyze the patient's genetic data, the treatment history, and response patterns to help recommend the most effective chemotherapy or radiation regimens based on similar cases. So improve care coordination. We can identify individual risks and using these predictive models and at the same time, be ready for preventive care, optimize medication management for elderly, for example, for elderly patients. Taking multiple medications, big data analytics can help nurses identify potential drug-drug interactions and suggest alternatives or dosage adjustments to avoid adverse effects. And of course, there is a precision in post-discharge care because after a patient is discharged, nurses can use big data to monitor patient outcomes and adherence to care plans remotely. Mental health monitoring, very important, including data from apps, from wearable devices. This allows nurses to track a patient's mental health over time. So by using these tools, nurses can provide personalized mental health support and interventions based on the specific triggers or conditions a patient is experiencing. For example, for a patient who has depression or anxiety, nurses can do what? They can monitor data from mental health apps to identify patterns in mood changes or behavior. And this provides personalized counseling, also therapy recommendations. So we talk more enhanced patient engagement because nurses can now define the best methods of communication for individual patients, whether this is face-to-face interaction or phone calls or text reminders, and adapt their engagement strategies accordingly to ensure better adherence to treatment plans. And in what ways can nurse informatics improve patient engagement? There are all these patient portals which allows patients to access their own health records, the lab results, the medication lists, appointment schedules. We talk about transparency now, and this transparency gives patients more control over their health and fosters informed decision making. Informatics tools can provide educational materials tailored to individual patient needs, helping them to understand their conditions, the treatment options, self-care practices, which improve self-management and health outcomes. Facilitates the communication, two-way communication between patients, healthcare providers, for example, through secure messaging systems or telehealth consultations or mobile apps. We talk about an ongoing dialogue which allows patients to do what? To ask questions, to clarify concerns, to feel more involved in the care decisions. And at the same time, collaborative tools to collaborate with other healthcare teams to provide coordinated care, keeping patients informed and involved in decisions about the treatment options. So more data-driven insights, targeted alerts and reminders, the remote monitoring, and mention how to encourage self-management through mobile apps, mention real-time feedback, patient-reported outcomes or service and feedback are important. Decision support tools and patient decision aids. And how to build trust and confidence because I mentioned before about transparency now and accuracy. So very important that now we can predict the patient outcomes. How? By identifying risk factors and patterns, by predicting disease progression, predicting hospital readmission, because we can identify patients who are at high risk of being readmitted to the hospital after discharge by analyzing factors such as prior hospitalization records or socioeconomic factors and comorbidities. So hospitals and care teams can therefore intervene with additional support or follow-up care to reduce readmission rates. So these predictive models mentioned before, based on patient genetic makeup, on lifestyle data, clinical history, AI now, and machine learning, all these learning models can predict how patients might respond to specific treatments or interventions, allowing doctors to make more informed decisions on the best course of action. This is what we call personalized predictive models. And at the same time, we talk about precision medicine, because big data enables precision medicine with tailored treatments based on the patient's genetic makeup that I mentioned before. And by analyzing this, we can help healthcare providers design therapies that are specifically suited to an individual's biological profile, minimizing this way adverse effects and optimizing outcomes. For example, in oncology, big data helps identify which cancer treatments would work best for a specific genetic mutation or cancer subtype, leading to better response rates. So this helps us to design more dynamic and adaptive care plans, helps us with decision support systems, and of course, the benefits is what I mentioned before. It's about early detection, it's about improved outcomes, reduced healthcare costs, and how these tools enhance communication, especially between patients and healthcare providers. I mentioned before about electronics health records. And this allows providers to access comprehensive, up-to-date patient information anytime, anywhere. So this facilitates more accurate discussions about patient care, whether in person or via telehealth platforms. It's about streamlined communication because nurses and other healthcare professionals can update and share patient data immediately with the rest of the team. And this reduces delays and ensures that everyone involved in the patient's care is on the same page, minimizing misunderstandings. It's about direct communication tools, online platforms, portals where patients can access the health information, communicate with their health providers, schedule appointments, etc. And of course, this promotes engagement. Securing messaging systems for instant communication, continuity of care, because these secure messaging tools ensure continuity of care by allowing patients to follow up on their conditions or ask questions between appointments. And healthcare providers, of course, can respond too quickly without needing an in-person visit. Remote monitoring tools, which enable continuous communication, clinical person support systems, so enhance information sharing, reduce communication. The chatbots not only offer night and day access to communication, but also what we call pre-consultation preparation, because virtual assistants, AI assistants, can gather basic information about the patient's condition before an appointment, so allowing healthcare providers to have a more focused and efficient conversation with the patient during the consultation. The social media, of course, data analytics and feedback tools. So some examples of patient health technologies is, I mentioned before, for example, patient-generated health data. It's about wearable devices and mobile apps, such smartwatch or fitness trackers or health apps, which collect data such as steps taken or the heart rate or sleep patterns or even glucose levels. So patients can share this data with their healthcare providers to adjust care plans and monitor chronic conditions like hypertension, etc. Here also we talk about chronic disease management because we can tailor treatment for chronic disease patients based on real-time information before. So personal health management apps, symptom trackers, and education. These are apps that allow patients to track symptoms, to pain levels also, or mental health concerns with tools for managing conditions like asthma or anxiety or depression. More interactive, talk about more interactive health education, how AI also helps us a lot, and patient safety technology is here what we call, for example, the barcode medication administration, because this technology actually allows nurses and healthcare providers to scan a patient's barcode, a medication barcode, to ensure that the correct medication is administered at the right time and dose, reducing medication errors. And secondly, we call smart infusion pumps. These pumps are equipped with sensors that can automatically adjust the medication delivery rates based on the patient's condition, reducing the risk of human error and ensuring the correct dosage. So many options that we have here. Some examples of technologies. Interactive telemonitoring also I mentioned. How we can improve clinical decision making. Already mentioned some things, but this evidence-based decision making is very important because we make decisions now that are based on the latest evidence and best practices. For example, a nurse treatment, a nurse who treats a patient with a respiratory condition can quickly access evidence-based guidelines for medication management for respiratory therapy and care intervention, ensuring that decisions are aligned with the most current standards of care. Big data systems, when they are combined with tools like electronic health records and wearable devices, provide nurses with real-time patient data and alerts at the same time. For risk assessments, we can streamline diagnosis, we can optimize the care condition, we can enhance at the same time critical thinking and diagnostic skills, because big data provides nurses with access to a wealth of information that can enhance the critical thinking and these diagnostic skills. Why? Because by analyzing patterns, outcomes, and large data sets, nurses can gain deeper understandings and insights into patient outcomes and make more informed decisions in complex situations. Post-discharge planning, that I mentioned before, and improve clinical workflows. So what decision support systems are available? Clinical decision support systems have to do with alerting systems with guideline decision support. These can recommend care protocols based on best practices or clinical guidelines. For example, when we manage a diabetic patient, the system might suggest the glucose. For medication decision support systems, here, what are the characteristics of the system? For example, dose calculation, the drug interaction checks, warn clinicians about potential harmful drug interactions in real time. It's amazing. Medication safety alerts, flags medication that may be inappropriate for certain patient conditions or characteristics, for example, for pregnancy. We have up-to-date clinical decision support tool that offers the recent evidence. Cochrane Library provides systematic reviews of healthcare interventions to support decision-making and clinical pathways, which actually are standardized in evidence-based guidelines. Risk assessment, the predictive tools examines the early warning systems, which can help us with spotting patients who are at risk of deterioration, analyzing the vital signs, or the sepsis prediction models. At the same time, the full risk assessment, tools like the Morseful scale actually evaluate factors such as mobility, medication use, etc. The symptom decision trees are algorithms that guide clinicians through a step-by-step process of considering various diagnoses based on patient data, clinical signs. The order sets and protocols, an example we can mention pediatric or post-surgical order set, the sepsis protocols, and also charting, the nursing technique support, so charting documentation decision, the coding assistance suggests proper coding for diagnosis, for treatments and procedures, the telemedicine virtual health platforms, the flowchart-based support, decision support embedded in workflows and provide recommendations, the AI systems, so risk stratification. These algorithms that analyze patient data to predict outcomes, the natural language processing, and with all these possibilities, we can identify early warning signs of patient deterioration. We have risk stratification, predicting accurate events, improving communication, the post-accurate care and follow-up. What types of data are most useful for preventing medication errors or detecting potential safety risks? These types of data, as I mentioned before, patient health history, laboratory diagnostic data, medication administration data, drug interaction data, pharmacy data, all these are important, are precious for preventing medication errors. And of course, big data contributes to reduction of hospital-acquired infection and other adverse events. Through antibiotic stewardship, enhanced hygiene, clinical protocols, tracking, monitoring surgical sites, another very important issue has to do with health population health management. And this, why? Because big data can help us now first identify and address health disparities. We can understand how now big data can reveal that a particular low-income community has higher rates of asthma due to poor air quality. So nurses now can do what? Can coordinate efforts to provide better asthma management, educate the community about environmental triggers and advocate for policies to improve air quality. For example, another issue predicting disease outbreaks. During flu season, big data from emergency room visits through related searches online and public health reports, this can help predict potential outbreaks. Nurses can use this information to increase vaccination efforts and educate the public about preventive measures. Many amazing possibilities. We can monitor trends in blood sugar levels among diabetic patients. So for chronic disease management, the resource allocation can help us behavioral social determinants on health. They might reveal, for example, that low-income families are more likely to experience preventable hospital admissions due to poor nutrition. So nurses can work with community organizations to provide access to healthy food, education, and affordable nutrition support services to address food security. More targeted public health campaigns. This can help improve vaccination, immunization programs, reducing health disparities, and so many insights that nurses can gain through emerging, for example, identification of health patterns that could be emerging infectious diseases or seasonal geographic variations, through risk prediction, through tailoring treatment plans. So we actually, informatics can help identify health disparities at risk population also. And in general, of course, this helps with policy making by targeting public health interventions, behavioral sentiment analysis, monitoring health equity, and disparities will help us with global health and cross-border collaborations. And the data from community-based health programs, of course, can be integrated into nursing care plans. We need to leverage incorporating social determinants of health data, the collaboration of community health workers, patient education managers support, all these health information exchanges, all these very important data that we can integrate into nursing care plans. Of course, help us with workflow, optimization, and through clinical communication tools, patient flow management tools. The benefits of automating data entry, of course, has to do with time saving, with cost savings, with streamlined communication, more enhanced compliance, and regulatory adherence, better job satisfaction, improved, of course, patient satisfaction. The reduction of administrative tasks also is important. The common challenges before concluding have to do with more time for direct patient care, better workflow, the faster access to patient information, the improved data for research, the cost savings, etc. So, of course, there are challenges. But these amazing tools that we have, for example, wearable devices, which help with data-driven support and support for clinical research. Let's not forget about the ethical considerations. Ethical considerations are very important to talk about the healthcare sector. Data privacy, data quality, interoperability, the data overload, the lack of standardization, and how healthcare organizations can address these concerns, these challenges by encryption of data, by regular audits and monitoring, by securing data storage, by setting up a data breach response plan. Of course, through patient consented control. Blockchain technology is important for enhanced security. Of course, what steps before concluding can be taken to prevent data overload? When we work with large healthcare datasets, of course, we start with data prioritization, then aggregation, use of advanced data analytic tools, then we develop clear data visualization techniques, the data governance, we segment, we structure the data, we implement role-based data access after the regular training. We try to balance real-time data with historical context, data compression, and clear documentation communication protocols. Very important steps that you need to follow ongoing training and education is important for nurses if you want to use these informatic tools. So optimizing patient care and safety, we have to incorporate data analytics. We need to train on this, and of course, they need to be ready to face these ethical issues that may arise, such as data accuracy, the bias, discrimination, the data ownership, the informed consent, the equity in data access. The future trends, emerging trends in nursing informatics, also related with AI, cloud-based healthcare systems, blockchain, robotics, automation in nursing, You can think about how you see the role of artificial intelligence, how this has improved your work, the diagnosis, the personalized care, and of course, these advancements in wearable technology are expected to impact nursing practices through continuous remote patient monitoring, through this wearable for medication adherence, pain management, echocardiograms, smart clothing, etc. We could say, conclude, thanks a lot for your attention. You know, I can speak for hours, but I know I have to stick to the time. Thank you very much for giving me this opportunity. If you have any questions, of course, we can discuss.
Thank you so much, ma'am, for this informative session. It was good to have you with us today. Thank you so much, ma'am.
Thank you for this opportunity. If you have any question, of course.
Anyone has any questions from the audience? No, ma'am, no questions from the audience.
Okay, thank you very much, thank you.
So now we will take a break. It's time to have your lunch. The designated venues, I'll repeat for one more time. All the guests, speakers and chairmen, your lunch has been arranged in the VIP lounge, left toward from the outside, and all the student delegates and faculty delegates, your lunch has been arranged in the ground. Thank you.